This presentation will explore cognitive behavioural therapy, or CBT. We will guide you through the development and theoretical background of CBT, its use in a nutrition and dietetic setting, and how it's used in research. First, the theoretical background and development of CBT will be explored. Cognitive behavioural therapy is a form of psychotherapy which focuses on an individual's thoughts, feelings, and behaviours. CBT suggests that early life experiences help us form core beliefs about ourselves, the world, and the future. These may be positive or negative. For example, I am lovable or I am worthless. Core beliefs tend to be inflexible and can be identified by observing how someone reacts to an event. These interpretations may stem from cognitive distortions or negative automatic thoughts. CBT aims to help patients identify dysfunctional thinking and behaviour patterns and replace them with more adaptive ones. For example, negative automatic thoughts are identified and replaced with more realistic thoughts by looking at evidence for and against each thought. This helps prove why the thought is not realistic. Cognitive behavioural therapy has been developed based on behavioural therapy and cognitive therapy. Originally, behavioural therapy was developed to help treat the major emotional trauma, depression, and anxiety experienced by World War II veterans. CBT has been modified over time as more modern and effective approaches have been discovered. There have been 3 waves in the development of CBT. In the 1940s, behavioural therapy was developed by Pavlov, Skinner, and Whoop. This was based on the process of learning and how it affects our behaviour. Its aim was to immediately change behaviours through conditioning or reinforcement. The second wave involved the early development of cognitive behavioural therapy by Beck and Alice in the late 1960s. They studied how behaviour and emotions are affected by thinking. They aimed to change thoughts related to certain behaviours directly. Wave 3 is a more recent adaptation of CBT called mindfulness-based cognitive behavioural therapy. This was developed in 2004 and incorporates mindfulness to change thoughts and patterns of thinking in certain situations or events. It teaches people to view thoughts and feelings as passing events rather than necessarily a reflection of reality. This therapy was largely used to prevent the relapse of major depressive disorder. However, it is now being applied in other areas. CBT is used because it has the ability to reduce various symptoms of psychological disorders and negative automatic thoughts. Cognitive behavioural therapy is different to other approaches as it focuses on current problems or behaviours rather than past matters. It also allows the treatment of some disorders without the use of medication. When it was initially developed, cognitive behavioural therapy was mainly used in psychological settings for depression, suicide, and anxiety disorders. Now, its use is more widespread and includes medicine, nursing, social work, and nutrition. It's used to assist people to better cope with management of diseases and symptoms. There is a large body of evidence to support the effectiveness of CBT. In a nutrition and dietetic setting, CBT can produce large improvements in eating disorder symptoms and treatment adherence. Cognitive behavioural therapy is also used to improve the symptoms of irritable bowel syndrome.
So now we will look at the use of CBT in a dietetics and nutrition setting, specifically through assessing the understanding and use of this counselling style by a dietitian named Joanna Lang. Joanna Lang is in her first year of practicing as a dietitian after completing her master's studies at Deakin. She had connections with some of the other dietitians working at Discover Health in Eltham, and this led her to being offered her first job in private practice there as an accredited practicing dietitian. She does not currently work in any setting other than private practice. However, she works across the various Discover Health locations. Joanna specialises in women's and maternal health, including gestational diabetes and PCOS, which is largely due to her clinical placement being based at the Royal Women's Hospital, where she hopes to work one day. Most of her clients are middle-aged, however they do range from as young as 18 years to the elderly. The interview with Joanna was structured by being broken up into 3 distinct sections made up of introductory questions, questions specific to Joanna's understanding and use of CBT, and finally some additional questions addressing limitations and barriers of CBT use in a nutrition setting. Subsequently, our questions were developed so that they began quite broadly and increased in specificity as the interview went on. Doing some basic research on maternal nutrition also guided our question development. For example, linking questions to relevant examples like someone struggling with weight gain during pregnancy. Overall, our approach to the interview was to first build rapport with Joanna and gain an understanding of her background, and then to tweak or fine-tune our pre-developed questions in order to guide the interview in the appropriate direction. Joanna had a clear understanding of the fact that CBT is to do with the emotional and mental side of behaviour change. However, she lacked the understanding that it is largely about the transition from negative thought patterns to more positive, healthier ones. Interestingly, when asked if she used CBT throughout her practice, Joanna was initially quite adamant that she did not use it and would not even know how to go about it. She also stated that most of the clients she works with have black and white cases, and it is more about the education than behaviour change. However, as the interview went on, various questions prompted Joanna to realise that the fact that she often works with clients to get rid of the emotive power of food and identify behaviours and barriers that are causing their struggle meant she was actually using CBT unknowingly. Thus, this idea that counselling skills such as CBT are often subconsciously employed by dietitians became a central theme to the interview. When Joanna expressed that the use of CBT sometimes depends on the client's condition and how much time it takes to address that first, it was highlighted that time is a barrier to the use of CBT in a nutrition setting. Further, comments such as patients who need further work in the emotions and behaviour department are referred to psychologists suggest that an additional barrier to the use of CBT by dietitians is that they don't feel it is necessarily their job to do so. While CBT was not consciously used in Joanna's case and she highlighted various barriers, this may not necessarily be representative of how other dietitians might practice. Given that Joanna is a graduate dietitian, it may be likely that she has not yet established the skills that more experienced dietitians have to be able to give nutritional advice as well as actively focus on employing CBT. Further, CBT is perhaps a counselling style better suited to certain conditions such as eating disorders and/or children with fussy eating or autism, and therefore Joanna's minimal use of CBT is likely not reflective of dietitians practicing in these other niches of the nutrition setting.
So now we will be looking at CBT in a different context again, that being in the context of how it can be applied in research as a tool, methodological component, or intervention. Initially, CBT was mainly used in a psychological setting for depression and anxiety. However, in recent times, it has become more appropriate for CBT to be used in other areas of healthcare, including dietetics. There is evidence that CBT is particularly effective for irritable bowel syndrome and also certain eating disorders. Thus, this literature review aims to investigate the effectiveness of CBT on reducing symptoms of irritable bowel syndrome and various eating disorders, namely anorexia and bulimia. In conducting the review, the Medline database was used. First, keywords were searched. These included CBT or cognitive behavioural therapy and eating disorders or anorexia nervosa or bulimia, or IBS or irritable bowel syndrome. Following the keyword search, specific inclusion and exclusion criteria were applied. Firstly, articles were required to be in the English language and be published during the last 10 years. This search generated 259 articles. Further inclusion and exclusion criteria were then applied, which included the articles being peer-reviewed and including more than 40 participants. The resulting studies were reviewed and assessed as to whether they met the specified criteria, which resulted in 6 articles being selected to carry out this literature review.
After thoroughly reading the chosen 6 articles, it was found that all articles had similar findings regarding the success of CBT, despite differences in timing and approaches. 2 of the 6 articles were related to IBS. While both indicated that CBT was able to improve IBS symptoms, Wynne-Gusson et al. Found that CBT delivered face-to-face in the initial weeks of treatment was able to improve symptoms in IBS patients, whereas Lackner et al. Found that a home-based, self-managed CBT approach with minimal therapist contact was effective in reducing symptom severity for those with IBS. Additionally, this second study also showed that greater long-term improvements, patient adherence and satisfaction could be seen in a home-based CBT approach as opposed to the use of IBS education for these patients. Of the remaining 4 articles, 3 were related to the effectiveness of CBT treatment in reducing the symptoms of anorexia and bulimia, while the last focused specifically on therapist adherence to CBT treatment in relation to bulimia. All 3 of the articles regarding symptom reduction found that CBT resulted in an improvement in eating disorder symptoms, which included improved quality of life, BMI, and general psychopathy. In regards to bulimia specifically, improvements such as better eating attitudes and reduced binging, vomiting, laxative behaviours, and depression were seen in all articles. However, one study also found that patient engagement played a role in this reduction of symptoms, where patients that were effectively engaged in CBT reported greater short-term and long-term improvements. Finally, the study relating to therapist adherence to CBT found that higher levels of therapist adherence during the early and middle stages of treatment resulted in a reduction in the frequency of binge episodes, whereas higher adherence later in treatment did not. In conclusion, it can be said that the introduction of CBT in the initial weeks of treatment is effective in reducing symptom severity of IBS and eating disorders. However, increased length of therapy does not necessarily result in better outcomes. Patient satisfaction to different CBT approaches can also alter effectiveness. It is important to note that further research needs to be conducted on CBT in a dietetic context. As can be seen through this presentation, cognitive behavioural therapy changes behaviour by altering our thoughts and the way we see the world. This is done by helping patients to identify and change negative or distorted views into positive, more realistic ones. Furthermore, it can be seen that cognitive behavioural therapy is employed in some areas of the nutrition and dietetic setting. However, some dietitians are not necessarily aware of their use of CBT, and so they could benefit from more training in this counselling style in order to employ it more effectively in their practice. Subsequently, while the literature shows that CBT is effective for treating eating disorders and IBS, further research needs to be done on its effectiveness in other dietetic settings. Thank you very much for listening to our presentation.